This expose will be hosted by myself, Maisha Phelps. I am Community Engagement Coordinator for UCSD and CalCenSyn, the California Center for HIV Syndemics and Policy Research, which is led by a miraculous team. And we have a lot of talented individuals joining us today. And I will go ahead and allow my compadre, Xavier, to introduce himself.
Thank you, Maisha. Welcome in, everybody. It's nice to be here today with y'all. My name is Xavier Laporta Sanchez. I am currently the Director of HIV and STI programs for St. John's Community Health in Los Angeles, California. I've been doing HIV work and program management, program implementation, and consulting for around 10 years now. And of course, this topic is near and dear to the work that all of us do on a daily basis. We know that uh, social determinants of health play a huge role and have a huge impact on the people that we serve and their health. And this, I think, housing specifically is one of those social determinants of health that is usually overlooked, and the huge impact that it has on how people adhere and recover in their health journey. So welcome in. I echo Maisha's words. We have a great plethora of professionals here presenting today. We would like to, well, I'll let you do that announcement, Maisha. Go for it.
So without further ado, we'll go ahead and get started. Here at CalSynCen, we are, like I said, we're a community collaborative which brings together organizations from across California. You're going to see a representation from the top, as I like to say, Shasta, Siskiyou, all the way down to North Mexico here in San Diego County. So you have a well-versed group of individuals spanning across different subject matter expertise, various walks of life, and that is our foundation. We are a collaborative that includes UCSD, UC San Diego, along with UC San Francisco, led by Drs. Laramie Smith and Dr. Orlando Harris from UCSF. This also includes a myriad of CAC partners, as we're called, community academic collaboratives, including organizations like DAP Health, also San Diego Harm Reduction Coalition, as well as Oakland LGBTQ Center and Sacramento LGBTQ Center, along with some of our other PWIT partners, including my co-host today, Xavier Laporte. And hopefully we will be having some new PWIT partners to help really channel the way that the community sees how we might be able to overcome some of these syndemics and social determinants from the people, not from a top-down approach, but from a collaborative conversation on how we may shape policy going forward. So be that as it may, we want to make sure that we highlight our presenters, of which we're going to be presenting these housing studies that we have worked so diligently, which will be reviewed by True Evolution, an amazing organization out of the Inland Empire. Townspeople, a wonderful organization that is working towards housing solutions for a myriad of community members, as well as East Oakland Community Project, which is holding it down in my hometown area of the Bay Area. So thank you all for participating today. Thank you for showing up and showing out. We will have discussion and questions, and then we'll have a closeout and evaluation that I need you guys to make sure that you participate in, because if you know better, you'll do better. But you got to share that with us, right? So without further ado, once again, make sure that you're muted and let's get this party started. And so now, as we've got class in session, as I like to say, we're going to take a few moments to to highlight our CalSynCen migration study by Dr. Tommy Gaines. Dr. Tommy Gaines is a professor in the Department of Medicine at the University of California, San Diego. As a Southern California native, she spent over a decade conducting research to improve the health and well-being of historically overlooked communities. Now, Dr. Gaines currently works with multiple Southern California tribal communities on substance use and overdose prevention. Her work is grounded in a strong commitment to health equity and elevating communities-driven solutions. So, without further ado, my good friend, Dr. Tommy Gaines.
Thank you, Maisha, for that wonderful introduction. And if it's okay, I'll go ahead and share my slides. Good afternoon, everyone. Glad to be able to speak with you all today about some work that myself, as well as other academic and community partners, have engaged in over the past year. And so the title for today is As Californians Move, Do HIV Prevention Services Follows? And this was a project where we were interested in mapping out where people were moving. So what do those migration patterns look like, as well as where HIV prevention services located, particularly when it comes to 3 ending the HIV epidemic counties. So the motivation for doing this work was really around California's changing landscape when it comes to prevention or HIV prevention services. But first, just to give you some context of what's happening in California, we are a state that's highly burdened by HIV. I'm sure many of you are well aware of this. But in terms of statistics, we rank second, across all states in regards to HIV diagnoses. And within California, our HIV burden is concentrated primarily amongst Latino, Hispanic Californians, as well as Black and African American Californians. These two groups combined account for 72% of all HIV diagnoses in our state. And it's an epidemic that's concentrated within our young adult population. So it's those between the ages of 25 to 34 who are most affected here in California. Now, in terms of EHE counties, some of you may be familiar with this, but back in 2019, the U.S. Launched an initiative called Ending the HIV Epidemic, or what I'm calling EHE. And the purpose of this Ending the HIV Epidemic initiative was to focus on areas that had the highest burden of HIV. So in other words, they went to the places where more than 50% of HIV infections were concentrated at. There's a total of 50 such places in the United States, 8 of those being here in California, or 8 priority counties that have been identified for scaling up HIV prevention and treatment resources. So not only do we have this high burden, we also have a lot of people looking to California to invest in prevention and treatment so that we could stop the transmission of HIV. But what we're also seeing is this changing landscape in terms of housing costs. This isn't something new. It's a national problem, right? That housing costs are going up, leading people to move to new areas. So we were interested in mapping that out. We know that people are moving not only outside of California, but also within California. So we wanted to map out this population movement across counties because this could potentially lead to a shift in where they can access these services for HIV prevention. So ultimately, why this matters is because we know, first of all, housing instability does increase HIV risk. And also, for people who are moving to more affordable counties, they could potentially be disrupting their access to HIV prevention services. So in doing this work, we just started off with this overarching question, which was, where are people moving from, and where do they end up? Are they ending up in places where there are still HIV services nearby? And as we were focusing on these 3 EHE counties, we looked at both Southern California and Northern California. First, starting off in Southern California, we looked at San Diego County, and we specifically went to the U.S. Census data to see, well, if someone's moving out of San Diego County, where do they end up at? And what we found is that for people moving out of San Diego County, most were ending up here in Riverside County. We did the same thing for Los Angeles County, which is another EHE county, meaning it has a high burden of HIV diagnoses, as well as a place for targeting prevention and treatment services. So in looking at census data from Los Angeles County in terms of where are people moving to, what we saw is when people do move out, they tend to be moving to San Bernardino County here. So in Southern California, we were focused in this region of San Diego, Riverside, San Bernardino, and Los Angeles, which also happens to be all EHE counties, meaning counties that have a high burden of HIV, but also have been counties targeted for scaling up prevention and treatment resources. In Northern California, we focused on San Francisco. Again, looking at that census data, what we saw is that when people do move out of San Francisco County, they were primarily relocating to Alameda County. So this region up here in Northern California. Once we figured out where people were moving to, we then decided to focus our attention on places within these counties that could be more vulnerable to HIV. And we were defining vulnerability by the area's demographic and economic composition. So I'll share with you what we found in this mapping exercise. But before jumping into the maps, I think it's worthwhile for us to pause and just understand what all these different symbols and color gradations mean. So here we're starting off in San Diego County with people primarily relocating to Riverside County. Down here being Riverside, up here San Diego. On both maps, which you'll notice are stars that are color-coded from yellow to red. What these stars represent are areas that were at increased risk of HIV. And the reason why we were designating these places as being at increased risk for HIV was because of the demographic composition of these areas, meaning they had age distribution as well as a racial ethnic distribution that reflected populations who are at increased risk or more vulnerable to HIV. These are also areas that had a higher proportion of households considered low-income renters. So the stars just indicate areas at increased risk of HIV, and the color reflects how long it takes to get from that area to the nearest HIV service provider. So yellow meaning less than 5 minutes, orange meaning 5 to 10 minutes, and red meaning more than 10 minutes. And then we also included on these maps the density of HIV prevention service providers, where if you see a light blue area, it represents very few providers, yellow all the way up to yellow, indicating a lot of providers. And then if you don't see this color gradation, it just means there were no providers at all in that area. And so as we start here in San Diego County, the good news is that we're seeing that for areas that were identified as being vulnerable to HIV, in other words, these stars, most of these areas within less than a 10-minute drive. When we move to Riverside County, again, the county where people are relocating to primarily if they're moving out of San Diego County, we still see a lot of areas which are vulnerable to HIV still being within a less than 10-minute drive, which is really good news. We did see a couple of red stars, meaning areas at risk for HIV being within more than a 10-minute drive. But overall, even when people were moving out of San Diego County to Riverside County, they were still in places that were nearby HIV prevention services. And we still saw really good coverage of HIV prevention service providers in Riverside County. The same was true when we looked at Los Angeles to San Bernardino County, in that when we identified areas that were vulnerable to HIV in Los Angeles County, again, these stars, many of these stars indicated that they were places or vulnerable areas within less than a 10-minute drive to the nearest HIV prevention provider. Similarly, with San Bernardino, we were seeing that same dynamic. Now, for those of you who are familiar with the county, you might be wondering, where is the top half of San Bernardino? Because we are only looking at the bottom half. And that's because San Bernardino is, I think, the biggest county in the United States, with a lot of the area being not densely populated or not populated at all. So for this map, even though it's a bit misleading because we're only looking at the bottom half, we are looking at the section where most of the population is concentrated, as well as service providers. But similar to LA County, even in San Bernardino County, we were seeing many areas that were vulnerable to HIV being within a short drive to a HIV service prevention provider. And then finally, this migration between San Francisco, with most people moving to Alameda. Now in San Francisco, we had a lot of sections of the county that had prevention providers. There's only one area within San Francisco that we identified as being vulnerable to HIV based on their demographic and economic composition. For those folks, though, who are relocating to Alameda County, still, many of those areas that we identified as being vulnerable to HIV were within a relatively short drive time to the nearest HIV service provider. So at this point, you might be asking yourself, okay, what does this mean? You're showing me these maps where people are moving outside of one county to another county, and it looks like they're moving to a region where they still have service providers. And that was our first thing that I'm pointing out here is yes, the good news is people are relocating. They're relocating to a county that still has HIV prevention services. But we didn't stop there because we know that proximity does not guarantee access. And this was where it was really informative for us to have our community partners be part of this research project because they helped us dig deeper into what does it mean beyond these maps. And so what we found is that across San Francisco, Los Angeles, and San Diego County, that HIV providers worked in a wider array of settings compared to Alameda, San Bernardino, and Riverside counties. And also, when people are relocating out of these three counties, San Francisco, Los Angeles, and San Diego, they were relocating to an area that had fewer medical providers. In other words, the density of providers per population was much lower, so less accessibility in terms of just having a medical provider around. And then ultimately, what we are seeing here is that just because a service is nearby doesn't necessarily mean that it's going to be known by people who live in that area or that they'll consider that service to be a welcoming space for them to reach out for HIV prevention. So in the end, what we're seeing here is that as Californians relocate, there is still a continued need for investment in these areas that historically have been under-resourced, particularly when we're talking about Riverside and San Bernardino County. And we need these communities to be able to expand their access to HIV prevention services to people who are relocating to these regions. So with that, I'd like to thank you all for your time. And again, just recognize our research team that include a combination of academic researchers here at UC San Diego, as well as our community partners. Thank you.
Thank you so much, Dr. Gaines. This has been a wonderful presentation, and it was an honor for me to be part of this as well. So to keep going, guys, up next we have Dr. Natasha Martin. And Dr. Martin is a professor and vice chief of global public health in the Division of Infectious Disease and Global Public Health. She is also the president-elect of the International Network of Health and Hepatitis and Substance Users. So without further ado, Dr. Martin, the floor is yours.
Thank you. It's so great to be here today. Thanks very much for letting me present our work. This is work that we have done looking at improving housing first substance use services and the potential impact that that could have on preventing HIV and hepatitis C among people who inject drugs. This is work that was led by myself as well as co-led by our two community partners at Harm Reduction Coalition San Diego, Tara Stamos-Busig, and at DAP Health, we had Monica Atchison and Zato Eldon. So we all know that homelessness is a key issue in California and that it is rising year on year. And we see increases both in unsheltered and sheltered homelessness year on year. And we also know that homelessness and unstable housing disproportionately affects some key groups, one of them being people who inject drugs, where in many places, the majority of people who inject drugs are experiencing or have recently experienced homelessness or unstable housing. Now, stable housing can have many benefits, improving, as we know, mental health, physical health, as well as financial health. But one of the key things that we wanted to focus on was how stable housing can reduce the risk of HIV and hepatitis C acquisition and transmission among people who inject drugs. So we know that because there have been research studies that have collated the existing evidence across a range of different settings, a range of different studies, and a range of different populations. And in this systematic review and meta-analysis that I am showing you, these authors, I was actually participated in this work, collated the existing global evidence that we have that looked at the benefits of stable housing on HIV and hepatitis C acquisition. And what this review found was that stable housing can reduce the risk of acquiring HIV by 28%. and reduce the risk of acquiring HCV or hepatitis C virus by 39% among people who inject drugs. So here we have quantitative evidence of the impact of stable housing on reducing the risk of an individual acquiring these infections. So what we did in our study is we used mathematical modeling. That's a technique that I have expertise in. We build simulation models to look at various impacts of policies and the potential current and future impact of policy change. And in this study, we use this mathematical modeling to simulate the impact of preventing entry into homelessness among people who inject drugs in San Diego, where 7 out of 10 people who inject drugs report experiencing homelessness. So we have a very high burden of homelessness among our population who injects drugs, and we can use the simulation modeling to try to understand the benefits of preventing entry into homelessness. So using this simulation modeling, we found that if we were able to prevent entry into homelessness, we could prevent 4 out of 20 new hepatitis C infections and 1 out of 20 new HIV infections among people who inject drugs over the next 5 years in San Diego. And these benefits would keep accruing over time, because all of these prevented infections would then prevent a cascade of onwards infections in the future, really having long-standing benefits. Now, housing first programs was also a key aspect that we wanted to explore with our modeling. Housing first is an approach where unconditional permanent housing is offered as quickly as possible, including voluntary wraparound services for substance use. This is the ideal. This is the sort of comprehensive program that, if achieved, should be the approach related to housing first. Now, unfortunately, what we see is that few housing first programs provide all their components. The good news is that California requires all housing programs to use this housing first model, but very few of them provide all these components, or what we talk about as operating at high fidelity. So this word high fidelity means that a program is able to deliver all the core components consistently as intended. Unfortunately, that does not happen consistently across California, even though our housing programs do use this housing first model. So what does that mean? What are the benefits of using this high fidelity housing first model where we're providing all the core components? Well, this was a research study that looked at the programs that were able to provide these consistent components and outcomes among people who use drugs who are homeless. And what they found on the bottom right is that people who use drugs that were in high fidelity programs offering all these components were more likely to remain housed once they obtained housing and less likely to fall out of housing. So when we feed that information into our simulation model, what we found was that if all of the housing first programs in San Diego County were to operate at high fidelity, these programs could additionally prevent a substantial number of new infections among people who inject drugs. The numbers here are on the right. It could prevent 647 new hepatitis C infections and could prevent 27 new HIV infections across 5 years. So in conclusion, what our work found was that California requires and supports these housing first initiatives, but we know that many programs operate at low fidelity or are just underfunded and can't provide all the core components. Our modeling indicates that if we are able to strengthen and expand statewide housing programs with all these core components, including voluntary wraparound services, intensive case management, and peer support for substance use, that could have potential substantial health benefits at preventing HIV, hepatitis C, as well as improving mental health, physical well-being, and financial well-being. And finally, we know that there's a need for improved support and trainings for the workforce who serve people experiencing homelessness, who use drugs, in order to enable them to provide this comprehensive model of care. So we put all this information into an infographic. It was front and back, as you can see here. And so if you want more details about our study, I encourage you to please look at that. I'd also like to thank all of our community partners that participated in this study, as well as CalCenSyn and the CHRP for their funding for this program. And I'm going to leave you with a short video, if I can manage to show that. I know showing videos is always a bit dicey when you're in presenting mode, but our colleagues at DAP Health did a wonderful job developing okay, here we go. Hold on. I need to make sure I'm sharing sound. I can't speak and do this at the same time. Okay. Developing a wonderful short media which explains in probably more coherent terms than I just did this work and the potential importance. So enjoy.
Hi, I'm CJ Toby with DAP Health. Here's something we don't talk about enough. Housing is one of the most powerful tools we have to prevent HIV and hepatitis C among people who inject drugs. And we know this because of modeling, which basically means using real data to estimate what could happen in the future if we strengthen housing programs. In California, we use a model called Housing First. It gives people unconditional, permanent housing as quickly as possible, along with voluntary support for substance use. But here's the problem. Not all Housing First programs are operating the way the model was designed, and that really affects outcomes. When Housing First is done with high fidelity, meaning staying true to the original approach, people stay housed longer, and HIV and hepatitis C transmission goes down. And the impact can be big. If every Housing First program in San Diego County operated at high fidelity, we could prevent 647 new hepatitis C infections and 27 new HIV infections over 5 years. Housing isn't a reward for recovery, it's the foundation that makes recovery possible. To see this full infographic, or to learn more about this research and why high fidelity Housing First matters for public health, visit chprc.org.
Okay, thanks very much. Very happy to chat.
Thank you, Natasha and Dr. Martin, rather, for this amazing work with you and the community partners. Exceptional. As we transition to our next guests and presenters, I want to introduce True Evolution. This collaborative team consists of Julianne Ballone, who is the Development and External Affairs Coordinator at True Evolution. She helps lead fundraising, grants management, and partnership efforts for the organization's housing, healthcare, and community programs. There's Sachi Banerjee. She is the Outreach, Linkage, and Testing Manager at True Evolution's Public Health Programs and Services Department. She leads outreach and HIV/STI testing initiatives that connect communities to health resources and supportive services. And lastly, but not least, we have Gabriel Astilleros, who is a client support specialist at True Evolution's Housing Department. He works directly with clients to help connect individuals with housing resources and supportive services, also connecting people to the care that they need. So without further ado, True Evolution, take it away.
Thank you so much. Good afternoon, everyone. Thank you for this opportunity to present about True Evolution in this webinar. We're really excited to present about our organization based in Riverside, California, and we focus on housing and HIV services. My name is Julianne Ballone. I am the Development and External Affairs Coordinator, and I'm also joined by Sachi Banerjee from our Public Health Programs team who oversees our HIV work, and as well as Gabriel Astilleros from our housing team. This is a brief overview about True Evolution. Our mission is to transform lives and build healthy communities, and we do this through wraparound services on one singular campus. We provide transitional housing, HIV care, LGBTQ plus resources. We are home to the Inland Empire LGBTQ plus Center in our region. We also provide behavioral health and workforce development on our campus. We were founded in 2007 by our CEO, Gabriel Maldonado, and we are celebrating 19 years this year, 10 years, about a decade or so, as a direct service organization and community power building org. We are based in downtown Riverside. Our priority populations include LGBTQ plus people, people living with HIV, transitional age youth, and seniors, but we are not limited to just these populations listed here. We serve anyone and everyone that needs services and who comes in through our doors seeking help. We also have 29 full-time staff employees in our organization. For our service areas, we serve both Riverside and San Bernardino counties, such a large and vast region of over 27,000 square miles, and we're able to go out to different cities in the region via our mobile health testing unit that Sachi will be able to go further more into depth. We go all the way out into Blythe as well, near the Arizona border, and provide HIV services and outreach. Some of the regional challenges that we see in our region include rapid population growth. We're starting to see more people come into Riverside and San Bernardino, which can increase the demand for housing and HIV services. We're also seeing rising housing instability and homelessness due to limited affordable housing and supportive housing in our area, in our region. As you may know, we are also chronically regionally underfunded as well. And we have shortages of health providers, services. Some of our clients face transportation and geographic barriers. And one of the things that True Evolution does is we do address transportation by providing Lyft rides for our clients. So that way they're able to access the services that they need and access care. And this is our housing program, Project Legacy, which was started funded by the Project Home Key initiative back in 2020. We held our grand opening for this campus back in June of 2023. On this campus, we house 48 residents, and we are almost always at full capacity. As you can see here, we have a large growing wait list of over 680 people on our housing wait list. And this really highlights the need of services in our region. Since inception of the program, we have reached over 2,000 clients for both housing and supportive services. And I just wanted to highlight here, there's a couple of highlights in this box, but one I really wanted to point it out was that our clients together have collectively saved over $96,000. And they're able to do this because they don't pay rent on our campus. We provide transitional housing. And so many of them have become stabilized, they have improved credit scores, and they also participate in financial literacy workshops or workforce development workshops that our team provides as well. And this is our model. This is how we address the social determinants of health. We really focus on a whole person approach for each of our clients. And we do this in, again, one singular campus. Our campus is about 1 acre. We provide housing, workforce development, wellness activities such as yoga. We also have a fitness center on our campus, behavioral health services, and as well as we have this one missing puzzle piece on the top, which is our primary and specialty care. And so I'm really excited to share with you that we are planning to open our True Health and Wellness Clinic this summer. We will provide medical services such as primary care and HIV services. We have a provider, Dr. Zane Endo. He's an internal medicine and infectious disease doctor, so he's able to provide primary care and HIV care at our clinic, and we're really excited to just bring this into the region. This clinic is only located like 5 minutes away from our current campus, so our clients, our residents, they're able to access this easily, and we can link them to care right away. We also have Landon Martin from our behavioral health team. He will be overseeing our services for behavioral health as well at the clinic. Now I'm happy to pass it over to Sachi to give an overview about our HIV work.
Thank you, Julie. So good afternoon, everyone. My name is Sachi Banerjee, and I'm the Outreach Linkage and Testing Manager for True Evolution's Public Health Programs and Services Department, or PHPS for short. A little bit about PHPS. We really are the boots on the ground conducting all the testing for the agency that is not done at our medical center. I will go a little more into detail in the following slide, but we basically conduct rapid testing through our mobile testing unit, or MTU for short, at outreach events and at our Health and Justice Center. And this is for HIV and hepatitis C rapid testing, as well as we're soon going to be introducing syphilis testing. We also provide linkage to care for individuals who are newly HIV diagnosed or who have fallen out of care, as well as for individuals that are seeking PrEP or PEP. We have a partnership with Planned Parenthood. So if someone has tested HIV positive through confirmatory testing at Planned Parenthood, my team would essentially go out to that center and link that patient to our supportive services, as well as to long-term medical care. And so we also do early intervention services and non-medical case management to really address any social determinants of health or barriers to medication adherence. With the clinic, we're also expanding to be 340B eligible providers, so we could provide discounted medication to our clients. Lastly, we have several support groups on a weekly basis at True Evolution. Some examples are our substance use focused support group called Finding Your Heart, which is essentially a collaborative group that we host with our behavioral health department to address the why behind substance use. We also hold several HIV specific support groups, such as our Spanish support group, our LGBTQ specific, our aging, our open, and our spiritually focused HIV support group, just to name a few. Next slide, please. So we really do everything from testing, linkage to care, and harm reduction distribution through our MTU. Our MTU is what my senior manager, Curtis Smith, likes to call the emerald of True Evolution. And it's through our MTU that we're really able to expand our services into the rural parts of San Bernardino and Riverside County. This year especially, we've been extra intentional about choosing our outreach and testing sites in cities that have fewer HIV slash STI resources. For instance, cities in the San Bernardino High Desert or going all the way out to Blythe. Our goal is really to address the gaps in HIV care for those living in the desert and mountainous regions of our very large grant area. And so that's a little bit about our department. I'm going to pass it off to Gabe to talk a little bit more about housing.
Hi everybody, my name is Gabriel Stieros. I am one of the client support specialists at True Evolution. We provide housing case management or housing navigation. So as Julie mentioned, Project Legacy is built to provide long-term stability, expand opportunities, and achieve independence. And we currently use a three-phase model. Phase one being stability, so establishing safety, consistency, and immediate support, whether that's through crisis intervention or just establishing routines. Phase two, which is exposure, so we expand opportunities for our clients, experiences, and community connection. And then phase three, which is autonomy. And so this is basically just supporting long-term independence and self-sufficiency. And so some of the populations that we serve are people living with HIV, seniors, transitional age youth, low-income individuals. We also have a partnership with UCR. So we house a couple of UCR students, as well as individuals experiencing homelessness. And our program is up to from 6 months to 2 years, depending on the client's individual care plan. And in 2025, we were actually able to transition 48 clients into permanent housing in just that year alone, which is super exciting. Next, please. Some of the supportive services that we provide at Project Legacy include a client council. So this is just a newly client council that we are trying to get our clients to engage and in civic engagement as well as providing health and case management, linkage to behavioral health, and in community partnerships with substance use disorder counseling, as well as wellness to workforce, and like Julie had mentioned, emergency transportation, food assistance, and hygiene. And we also offer community showers every Friday for just for community to come in and take a warm shower. Go ahead. Go ahead. Next. Hi, Julie. Can you move to the next slide? Oh, there you go. Some additional projects that we have are Project Room Key, which is essentially emergency housing. So we currently partner with two local hotels in the region. So for folks who qualify, we provide the hotel assistance. We also provide short-term rentals, mortgage, and utility assistance. So this is more for clients who have a late payment, who need utility assistance or mortgage payments. We can provide that as well. And then we also provide a CalAIM community support through Inland Empire Health Plan. And this is basically providing housing deposits, housing navigation services, and tenancy and community supports. And in the last in 2025, we've been able to help with over $55,000 in just housing deposits. So this is for clients to reach permanent housing. Go ahead.
Thank you so much. I think my Wi-Fi might have like dropped a bit, but I was able to come back. But that concludes our presentation, and you can contact us here. We also have our QR code to our website if you'd like to subscribe to our newsletter. Thank you so much.
Thank you so much to Revolution, Julianne, Gabrielle, and Sachi. We're wonderful partners for St. John's. And to continue the discussion, up next we have our wonderful people from Townspeople. And we have Stacy Drew, who is the Director of Support Services and has been with Townspeople for 5 years. As a licensed clinical social worker, Stacy enjoys using her skills to serve patients, staff, and the greater San Diego community. Stacy is passionate about helping the helpers and strives to build a positive work environment for frontline staff in this challenging field. When not at work, you can find Stacy thrift store shopping, yes, hiking in Mission Trails Regional Park, or going around with her family. Take it away, Stacy.
Thank you, Xavier. Share my screen. All right. Hello, everyone. I'm Stacy Drew, and I'm excited to share with you a little bit about Townspeople. We are a housing and homeless services provider in San Diego County, and we were founded in 1984 as a grassroots organization in response to growing housing discrimination in the HIV/AIDS diagnosed community. And since then, we've really championed housing for our community in San Diego County. And we are a small organization, and so we have focused on housing, and we really pride ourselves on being very resource connected in our community and having long-term relationships with our local medical providers and providers of all other resources for folks diagnosed with HIV. So here's some of the programs and services that we are currently offering. We own and operate 4 apartment complexes in San Diego for permanent supportive housing with a total of 119 units. 78 of those are specifically carved out for folks who are diagnosed with HIV. We receive all our referrals through our region's coordinated entry system, and really try to provide as many on-site amenities as possible, including case management, social activities, food distributions, etc. And to kind of piggyback on that, we have a supportive services team who is the department that I oversee, and we provide housing case management, on-site resident support services, to coordinate things like life skills training, linkage to resources, and social events for our residents. We provide basic household supplies for folks who may not have household goods due to not having been housed for a number of years or period of time. So we try to help them settle into home. We provide emergency food assistance and also transportation assistance. Historically, for the last 15 or so years, we've provided emergency housing via HOPWA for our region. And this program is coming to an end at the end of June. So we're kind of mourning that at the moment. But we have historically partnered with hotels around the county so that we could provide that short-term stabilization or that emergency stabilization for clients as they transition into permanent housing. A new initiative that we're very excited about is our shared housing program, which we launched at the end of 2023. And it is a tool that we want to offer to the San Diego County community. And we've kind of developed a system for our participants and for anyone interested in sharing housing to be able to locate a housemate in a safe and approachable way. And so we have built out an app through a housemate pairing tool called Bunkie. You can find it in the App Store if you're curious. And so our clients can go in and locate housemates in order to share the cost of living here in such a high cost housing market like San Diego. So one of the kind of it's intuitive solution, but for some reason it hasn't been explored so much in the homeless services sector. So we're really excited to start to normalize it here in San Diego and build out resources for folks to use. Another new service offering that we're excited about is our CalAIM community supports team. So as some of the traditional, maybe federal funded programs are becoming more challenging to acquire the funding, we're exploring other options, and CalAIM has been a great opportunity to continue some of the same services that we were providing. So housing navigation, security deposits, and tenancy sustaining services for our participants to help them locate and transition into permanent housing. Here in our approach has been to partner with a local hub so that we can provide services to all of the managed care plans here in San Diego County. And while we're not restricted to folks experiencing HIV, we're open to anyone in our community. However, we still provide that expertise that we've gained from the past 40 years of providing services to this community, as well as now some shared housing experience that we can leverage when working with our participants. So just some numbers about our impact from 2025. We were able to serve 590 individuals. And in our permanent supportive housing program, we had a 92% housing stability rate, which we're very proud of. And we saw 140 shared housing placements in this past year. So definitely seeing things that are working in housing our client population. Just wanted to, for those who aren't as familiar with housing and the homelessness sector, there are some real challenges ongoing, and so these are probably fairly expected, but affordable housing is obviously a challenge. Here in San Diego County, at least 135,000 renter households lack access to affordable housing. The results of our most recent point in time count just came out this past week. And it's been all anyone can talk about that we have an estimated 9,800 people experiencing homelessness on any given night in San Diego County. And then, of course, healthcare is a huge component. And as of 2024, we had 7.3% of our population who were uninsured in San Diego County. And And some new challenges started popping up in 2025 for obvious reasons, for lots of federal government changes, and some challenges were HUD moving away from that housing first model that was described in an earlier presentation as being so effective. And so that's been definitely challenging. There was a new HUD NOFO that was posted, a notice of funding in November that fortunately was withdrawn. However, will probably look very similar in this next round. So we're gearing up for a shift away from permanent housing and moving towards short-term solutions and more than likely imposing stricter work requirements for participation. That's what we're bracing for. And there's already been a lot of new policing of language and recommendations from our funders to adjust language on our websites, on our grant proposals, things like that. So definitely lots of I mean, we could go on and discuss forever some of how those things impact our community, but we've also seen in this past year just things that are working and that we definitely have things that we're excited about. We've been exploring a lot of new collaborative ideas to kind of bridge cross sectors with medical clinics, with employment providers, with academic research. So there's been a lot of increased collaboration that we've been seeing here in San Diego County. Um, we've we're really excited about shared housing. We're seeing it work, and it seems to be a quicker solution that folks can use to self-resolve more easily and take the lead in their housing search more effectively. Um, we're really excited about diversifying our funding sources and getting creative in that regard. And then we've also this year really put an emphasis on honesty and transparency in communicating our challenges with our clients so that they're aware of some of the funding challenges, some of the different pressures that are coming on to us, and that is getting communicated to our clients so that they're aware and can advocate and can make decisions for themselves to just be more informed. So yeah, very excited to share a little bit more about townspeople and happy to answer any other questions. And here's some ways to get in touch with us.
Thank you, Stacy. That was amazing. Love you talked about policy, you talked about housing, and healthcare. And I will have to say, I am quite proud of the people at Townspeople as I work with them and watch them tirelessly work to try to extend themselves to the community in under quite dire, climate right now. So thank you to you all. I would love to now introduce my hometown heroes, uh, East Oakland Community Project. We have here today Kamal Young, who has been with East Oakland Community Project Crossroads for nearly 5 years. And so up until May of last year, he was the HOPA case manager, HOPA standing for Housing Opportunities for People Living with AIDS. And he's now the substance abuse counselor. Kamal still works closely with clients from other caseloads, including HOPA, considering the bulk of Crossroads residents are SUD involved. He loves the HOPA program and feels privileged to be a part of serving his community in whatever capacity that he can. So without further delay, Kamal, please take it away.
Thank you so much. I will dive right into it. Alameda County has been having an exceptionally difficult time providing services and maintaining funding and keeping up with the rising tide of homelessness, specifically among the unhoused living in Oakland. As of early 2026, I believe March, an estimated 9,500 people experiencing homelessness in the county, with the city of Oakland holding over half the unhoused individuals and families. With the federal administration making cuts in the governor's race in full swing, EOCP, among other agencies, are holding on with little resources, bracing for a change in the state house that can make things easier, harder, or change nothing at all. Thankfully, the HOPPA program within EOCP and with many other agencies that we work closely with have kept above water. The medical case manager has had significant and consistent permanent placements and has maintained over, excuse me, 90% medication adherence and stable connection to primary care physicians and specialists like immunology. We work very closely with Highland Hospital, San Leandro Hospital, and Sutter as well. Although resources are ever scarcer, the HOPPA program has done well to utilize the city and county mandates for housing individuals with HIV and maintaining streamlined partnerships with programs like AHIP or AIDS Housing Information Project and CalPEP in West Oakland. These services provided by the HOPPA program here at EOCP do well to adjust to the volatile Bay Area housing crisis and provides comprehensive services up to and including assisting with document readiness, i.e. gathering documents such as ID, Social Security card, proof of income, and proof of disability. Here at EOCP, we've pretty much streamlined the process and usually get these people documented within 2 or 3 weeks. Our HOPPA program works closely with other programs that can provide medical services that may be out of our scope, such as referrals to EBAC at Summit Hospital. If the client comes into the program without a primary care physician, we also work closely with Roots Medical Center, and recently across the street, Baywell Mark have opened up. Referrals to the Bridge Clinic or Roots Clinic for mental health and or outpatient substance abuse treatment, which is also available within the shelter, along with recovery groups like CBT and Seeking Safety, which I run myself. The medical case manager is also tasked with supporting our HOPPA clients with essential life skills such as financial literacy and independence, banking and debt management, household management and daily tasks, personal and health and safety, professional and social skills, and job referrals. There are many challenges for the medical case manager and our HOPPA clients, even with the multi-agency partnerships. One consistent barrier in housing our undocumented clients. We have had several instances where a client will get matched to housing from the community queue or coordinated entry and will have all the core documents except one crucial for permanent or even temporary transitional housing. The medical case manager has worked with IIBA, Immigration Institute of the Bay Area, and has followed the success other agencies have had with their undocumented clients, but it seems positive results are rare and many clients are left in limbo. And the IIBA in particular has had to take on less and less cases as less people have been qualified and more people are being either in hiding or have been deported. Another challenge of our HOPPA program is keeping our clients present and engaged long enough to be housed. Although this is not unique to EOCP, it can be especially challenging having clients reach permanent placement in an environment with a high degree of risk behaviors right outside the shelters and oftentimes within them. Thankfully, EOCP has had a full-time SUD counselor, myself, for a year now, provides one-on-one counseling and recovery groups, which are starting to become more and more accepted and attended. But it can be difficult to maintain engagement considering it is not a dry facility, and most of our clients are SUD involved before they set foot in the shelter. I believe the largest barrier to our HOPPA program is the funding, which I'm sure is the same across the board. Federal funding continues to wane. Private donors are struggling themselves. The city of Oakland has just begun cleaning up its administrative issues with the new mayor, and the county is facing significant federal cuts along with significant legal issues and settlements. Simply put, there just isn't any money. And EOCP is having some real challenges with the city of Oakland right now, which has cut our case managers' workdays down to 32 hours a week. Although EOCP, like many other nonprofits, are struggling, there is still hope. When the financial issues have somewhat settled or given room to breathe, the HOPA program here at EOCP will be able to reopen our outpatient caseload for clients that have somewhere to stay but need housing navigation, clients that do not want to stay in the shelter but qualify for the program, or clients that have been housed but could use 6 months allotted a period of SSO or supportive services outpatient aftercare. EOCP and its HOPA program are in for a fight like many other nonprofits, but this skilled staff, diligence of the clients, and support of the community at large, we will be here to meet needs of our residents well into the future. Thank you.
Thank you, Kamal, and sending healing vibes to you for really showing up as we in the community often do, despite the current situation that we're facing. And I just want to give you a soul clap for being here and being present. So thank you on behalf of everyone here at CalSynCen in the community. Thank you. So, you guys all brought up some amazing highlights of your particular communities, both geographically, some of the geopolitics that you experience in your areas, and the various types of community members that you serve. So we want to go in and we want to take a moment. I want everybody put their thinking cap on, and I'm gonna get it started by asking some very pointed questions. We will open the floor, keeping in mind the time. You can also use the chat box, but I need you to lean in and show your stars and stripes by showing your expertise. And the first question that we're going to get started with is asking you all, how is the current housing crisis uniquely affecting people living with HIV or at risk of HIV in different parts of California not represented on this webinar? So for example, we have Fresno County, San Joaquin Valley, or other rural Northern California counties, or even out east. How is this crisis affecting those individuals? And as we think more inclusively to all of our areas. So I'll open up the floor for you all to talk, and we'll limit your responses if you can. And keeping in mind, we want to get a good array of individuals responding. And so, yes.
I do know that considering the prices in Alameda County are rising and no new developments are really going up, a lot of people are moving to Solano County, but the services that are available in Alameda County aren't following. So it's a very underserved area at a higher risk of not only homelessness, rates of infection, but also violent crime. So yeah, that's my 2 cents.
Okay, yeah, that's very interesting. We saw a great shift I'm from Contra Costa County and moving all the way up to Sacramento County and some people still commuting in San Francisco for work. So we've been seeing that over the past 20 years in how that is impacting service offerings as well. What are some of the other areas that are being impacted, as we talked about places like in Central California or even more further north? Do you guys have any input on in your work experience on how these areas have been impacted? Okay.
And Maisha, I think, as we talk about, areas that might not be as densely populated and maybe areas that didn't necessarily participate in this research and are not part of the agencies that are with us today. But I sit here and I wonder what was the impact of areas like Southern California. I mean, San Diego, close to the border, where we know our brothers and sisters from Mexico are constantly crossing over the border with the impact of the current political climate. How, our people that are here from San Diego, did you see a huge impact on HIV care with people literally migrating from their home country into the United States and vice versa?
Well, it's important that you say that, and I implore anyone from San Diego County to speak on their lived experience. I work with Haitian migrant women who have made a dire journey here from Haiti through South America and Central America with rights, with TPS status, and trying to develop a workforce from people with lived experience, trying to develop the capacity to be able to assist them is one of the communities that you're referencing. And people from Imperial County could also attest to having that, the border issues that we're having, and how do we meet the needs and the capacity when we're already at capacity, trying to help our current residents to be able to mitigate the risk of transmission and helping to care and linking those who are currently impacted into care. So it is something that we uniquely face here in the border regions, and we're still working to develop, that care model. But making sure that we have people representative of these communities as peers, as healthcare professionals and service providers is vital so that we can deliver care that is culturally aligned, right? And so Juan Esparza notes San Diego here, lots of people living with HIV clients that he interacts with, and they're feeling like they need alternate names because they're afraid immigration is a huge issue. So afraid that the public charge rule will be used against them, and afraid that ICE will be lying in wait outside of HIV and SUD clinics. And that is a reality that we face here. And so thank you, Juan, for providing your expertise.
We had Kimberly raise her hand. Kimberly, you want
Hi,
to unmute?
Kimberly.
Hi.
I'm from EOCP. I'm the case manager, service manager. And what I wanted to speak on was two things. One, with the housing first, that's a great model. But I worked in San Francisco 27 years with Department of Public Health. The issue that a lot of clients face is coming from the street after 10, 20 years, have no life skills and not able to maintain housing and end up homeless again because of different issues that they have not following rules and regulations. But my other thing is medical. If I say I'm in Alameda County and the client want to move to Marin, transferring your medical insurance over to another agency within a timely manner to be able to continue your services. People forget about that part. Like it don't happen just like overnight. And I just feel like people fall out of care, or you may get housing and you stop going to see your provider and your social worker because I'm housed now. I really was coming to see you because I needed to get housed. So now you're not taking your medication, just lost a follow up or, different issues that I think people don't look into. Like, just because I house you, that's fine. Yeah, you're off the street and I housed you, but are you able to sustain that housing and be able to follow the rules and regulations in that building? A lot of apartments are opening up places where it's working class people. There may be people that got imagine they're, homeless and they came into the situation, but you don't have the life skills to know how to turn off your radio at a certain time, not leave the water running. So you getting all these violations where they want to put you back out again, right? So it's that loss to following up with outside, like Kamal said, having aftercare to still support you. Because once I get you in, you still need support. So I just feel like that's a lot of the issues that clients have that been homeless 30 years. And now you got me a place now. Yeah, that's fine. But can I maintain that under rules and regulations? I was on the street. I didn't have to follow no rules. You have to follow
Mhm.
now. You can't be disruptive. You can't do these things. So it'd be the process of going from one situation to another and having that aftercare follow
Yeah.
up. Wraparound services are good. I worked with social workers, doctors, everybody. But after we gone, then what? Right? All these are doing a day. I got all these services I could bring you in a day. Swing shift come, you're just dealing with whoever's there, you know. So I just feel like looking into a lot of aftercare, life skills, like going and checking on people because I did a lot of outreach. I would go to your house. You have an appointment tomorrow with your doctor. You know, I can get you an Uber or a cab to get you there. But people have so many excuses, and we have to look at that too. Just because we house you don't mean everything just gonna change all of a sudden. All of a sudden, and with so many cuts, and you don't have places to put a lot of people.
Yeah. And Kimberly, you said actually something very interesting there towards the end, which kind of it's a segue, right? And I don't know. I know Sachi had her hand up at some point. I don't know if she would like to continue to contribute to our first kind of question of thought. But it's as we move through this housing crisis, and granted the the plowing machine that passed over us last year, beginning of last year, and all of us working in this climate, in this environment, and trying to provide services to all the populations that we serve, while funding cuts are happening left and right. How do we innovate in that space? What were the things that we did as agencies that helped us address and continue to address? Unfortunately, we understand that some agencies had to shut down because they couldn't just function without funding. But for those of us that kind of stayed in the game and put our best foot forward, what were the things that worked? What were the things that helped us continue to provide services and be successful at it? Do we have any outcomes, any clinical outcomes that we see an increase in our patients being less adherent, more adherent? Do we hold them closer? Do we let them go? We want to kind of rally the continue kind of the conversation to that piece. But Sachi, I see you have your hand up.
Hi, yes, it was more like a comment or just more like a story that there was this client that we had for several years, like 3 years, I believe. And he was an individual that actually was housed in one of our hotels prior to our campus being built. And so he was undocumented. And after leaving our transitional housing, we still did non-medical case management with him and, made sure he was adherent to care, showing up to his appointments, everything like that. He was coming to our support groups, doing very well. But his frustration was that he wasn't able to get the services that he was getting a few years ago due to budget cuts. He wasn't able to get transportation as smoothly to his appointments. He wasn't able to find housing after he left our transitional housing. He wasn't able to find a job because of his status, his immigration status. And then there was that extra added component that, ICE was in our area very heavily. He was so frustrated, he ended up actually going back to Mexico, and we had to actually connect him to care out in Mexico. And it's something that we're seeing happening. Our biggest fear is that our clients who are positive aren't feeling safe anymore and they're retreating.
Thank you, Sachi. That was definitely some insight. Julianne, you had your hand up.
Yes, I wanted to address the innovative housing model question that you had earlier, and that's exactly what True Evolution does. As we presented about Project Legacy, our housing model is not just housing, it includes behavioral health. We have workforce development, wellness programs, and that's kind of part of our development department here. And that's kind of how we see the sustainable piece in our model, is that we have these diverse portfolios that we can tap into. So we're not just tapping into housing dollars, we're tapping into, now that we're opening in our clinic, medical dollars, or Ryan White, et cetera, HIV care. That's kind of how we see the sustainability piece and how innovative we are becoming. We want to actually expand Project Legacy, and I want to introduce to you all like about our future project called Legacy Village, which just expands further on this piece from Legacy Village will be like our permanent supportive housing model that we're aiming to hopefully launch in these next upcoming years. But as you all know, funding is getting cut everywhere. The dollars are just like it's just hard to find. But I think as Truevolution, we find that having these diverse programs have really helped us sustain throughout this administration that we're all going through right now. And that's not like the only way we want to be sustainable. We want others to learn from our model as well. And so we really are a community power building organization as well, where we're like working with local LGBTQ organizations. How can they help sustain and transform their current business models so that they can also be sustainable as well in the future? But that's just a piece that I wanted to bring up.
Thank you, Julianne. And before Maisha moves on to our next question, I don't want to forget the chat. And I know Fernando stated that he is from, or they are from Los Angeles County, and they've seen a few of their patients in their 30s and 40s move to Orange County because they were able to get motel vouchers or low-income housing there. They've also seen a few patients over 50 move to Palm Springs last year and saw several patients under 35 move back to the South to live with family because they couldn't afford rent where they were living out of their cars or were couch surfing. And that's actually very interesting, Fernando, because when we did the migration study that I had the pleasure of participating in, that was the whole point, right? We see these migration patterns of people moving into areas where the cost of living and maybe the accessibility to housing is better. Um, where they can be a little more, they have more breathing room financially, but that was kind of the point of the Dr. Gaines' study is like, okay, but are the services moving? At the end of the day, we have people leaving because they can't afford to live in Los Angeles anymore. But are we as providers providing services to those people that are migrating? Because we have people, especially at St. John's, where we have the move to San Bernardino, even Palm Springs, especially our transgender individuals. We have over 10,000 transgender identified patients at St. John's, and we had a lot of them that were coming to their appointments from Palm Springs because they didn't want to use the services here or because there weren't enough services for them here either. So, Maisha, take it away.
No, these things are quite important, and that's why with CalCenSyn, albeit we have established ending the HIV epidemic areas, we want to extend the conversation to counties outside of that and explore how we can develop partnerships. And so I'll ask you all, how can we build stronger and better partnerships between healthcare providers, housing agencies, and community organizations to address California's housing crisis? Who is missing or who has been left out of this conversation or these partnerships? And also, what types of partnerships have been most useful in your work and why? So please open up the floor and share your thoughts.
I would say, this is Kimberly again. I would say a lot of outreach and a collaboration. When you have clients that have wraparound services, case conferences, so you can find out who else is on the team that you might be able to utilize in certain situations. So, like case conferences, you feel like the client has fallen off and they have a intense case manager, they have a doctor. We all need to get together and see what we can do to help, even if it's bringing in people that's providing housing for them, right? Because we want them to know that we put them into your property and we want them to be able to stay there. So I just feel like a good collaboration, and I'm gonna keep saying aftercare, follow up, outreach. I did that. That's what I would go do. Still take you to appointments. And so many clients, once they get housed, they don't go to appointments. So I'm gonna come take you to your appointment, right?
Mhm.
I'm gonna come remind you that you have an appointment. So those things where they see that you're not just putting them somewhere and just leaving them there now, you just on your own. That's what I would think.
And I would add to that, Kimberly, looking at and looking at the models that like UCSF 360 Clinic, as well as UCSD's Mother, Child, and Adolescent programs, which does not just this wraparound service, but really creates this very safe environment addressing the whole family, and using peer navigation as a model to be able to help bridge the gap between what some people would call patients and clients, right? Or patients and providers, rather. And so that is integral. And we see that especially in populations of women, who are very social beings. And humans just in general. It's not just that, okay, I throw this medicine in front of you. It's more so, do you have the behavioral health support? Do you have food? Do you have economic access? So it's, as we talk about syndemics, the pancake layers of all these drivers, but how are the coordinated services between all the players that contribute to healthcare also helping with housing? Because we know that housing is healthcare, right? And so the things that you brought up, Kimberly, are very, very key and vital. I also want to ask, what if we were to take a look at how we might be able to ingratiate people with lived experience of either housing insecurity and HIV? How can they play a role in being more meaningfully included in policy and program design? What has worked for you guys in your experience, and what has not worked well? I see a few people here that are outstanding and quite successful in their lives. I'm not going to call y'all out, but if you know, you know. So I would love for you to lean in and talk about, how those with lived experiences have been able to help to formulate that progress in healthcare. So I'll open the floor. Take it away. Or anything that you guys as providers are seeing in this space?
I noticed recently in the recovery groups I've been leading, the more I discuss my own recovery, the more I bring out other clients to not only discuss theirs, but process what people have shared in the group in general, coming up with ideas or discussion topics for next time, actually helping me develop more of a more comprehensive group. Once I just let a little bit out there, like, okay, I'm able to trust and relate to him a little bit more. Let me add something to it that I'd like to hear.
Thank you, Kamal. I see Apton.
Yes.
Mhm.
My name is Abteen. I know I'm kind of new to this group, but I think your question, I might have something to contribute. I'm a recent UCR undergrad student, and during my time there, I actually became somewhat of a community liaison with UCR School of Medicine because they are trying to develop their LGBT health education. And so, to sort of answer your question, I think one route to like reaching better health outcomes for people living with HIV, etc. But this is kind of a long-winded path, is supporting people who are currently scholars who have that lived experience, because that is what I had. And it becomes about, I think, identifying who who we um who is a community partner to us. And I mean quite literally like an individual person, and how can we continue to support that person as they are trying to ascend the various levels of academia or in the healthcare system, what have you. Maybe they're pursuing a graduate degree. So I think when we are able to preserve those ties, then as we lift that person higher, we see the effects come back down to where they started, the people who supported their journey from the get-go. If that makes sense, I hope that was said well enough.
Okay, Abstain, our emerging investigator. Leave it to the youth. I'm always like proud of you all, and thank you for your contributions. We hope to see continued great success for you in, the world of research and community activism as well. And I just want to thank you all for your contributions today. We are going to post a poll. If you guys can take a moment to fill that out, you'll see that come up on the screen. And we also would love for you all to share in continuing this conversation through our round two rapid research projects that here at CalCenSyn we are focused on. These research projects really amplify your voice and helping to address policy concerns for two topics. So we will be looking at the federal impacts of various cuts and policy changes as it impacts those living with HIV in the state of California. And we would love to hear your expertise. We are doing this study in focus groups in which we will leave the flyer here along with our contact information at CalSynCen for you to connect with us. And you will be compensated for your time because we are quite equitable here on our team. But we would love to continue this conversation with you all to gather information on how we might move policy to improve healthcare and also the settings for those who are working in healthcare, provider perspectives here in the HIV care landscape and prevention landscape. We will also be looking at burnout for individuals who are working in the substance use and harm reduction space. We want to know what are some of the things that you guys are experiencing and how we might improve that. So please, by all means, take a look at the chat box. We've posted a flyer. You can reach out to us at calcensenpolicy@health.ucsd.edu. And for more information, we will be glad to schedule time to talk to you. And along with that, please keep in mind, we are looking for individuals to continue helping us with these policy changes as our policy work in progress members meeting 3 times a year with CalCenSyn. So if you are interested, please continue to reach out to us at CalCensenPolicy@health.edu. We are so grateful for your contributions, and we look forward to continuing to work with all of you guys from every walk of California in every community. And thank you for all the work that you've done. Please be well. Have an amazing weekend, and God bless you all. Thank you.
Thank you for being here today, everyone.